Sometimes it's really busy, but it's actually busy because of the acuity of the patients, not the volume of the patients. So it might just be 120 patients that came through that day, but it can have been the craziest day ever because you had 2 or 3 ICU patients. It's helpful to see the overall number, but it doesn't necessarily accurately reflect how much work you had to do that day, not all the time.
We would have an 8:30 daily briefing meeting that would last between 5 to 10 minutes. Were there patient holds? Were there any impediments to patient flow in emergency services? And then the whole tone of the meeting was to look at the emergency department as the portal entry, and then to be able to respond to it as a team.
The main issue is getting discharges off the floor so that we can accommodate the patients in the emergency department that need to be admitted. So the hospitalists come prepared with the information about who's going to be potentially discharged that day. So throughout the course of the meeting, they give out the census on each floor, how many potential discharges they are going to have, and then they coordinate with case management and the physicians in order to get those discharges out the door. We give an overall bed status, kind of color code as far as how many beds we have available, green, yellow, orange, red. And then that way I can kind of plan the day for the emergency department.
The emphasis here is on patient care, quality, satisfaction, and patient flow. And a lot of times, we've gotten good enough in the ED that we expose things on the back end in the hospital that are not efficient. So you get to a point where you just have to make use of every square foot of real estate you have. But it takes someone with creativity, flexibility, experience.